Good afternoon to all of you and welcome. My name's John Finnegan. Just a warm Minnesota day, and we're glad to have you all with us. So, on behalf of the University of Minnesota School of Public Health, I want to welcome you. Thank you for joining this event today, Anti-Racism Research for Health Equity, the Vision, and the Promise. And today we're joined by Dr. Rachel Hardeman and Marissa Evans, and they're going to be introduced to you a little bit more formally in a moment. But I'd be remiss if I didn't mention our pride in counting Dr. Hardeman among the alumni of the University of Minnesota School of Public Health. As you may know, she received her master's degree in public health here and also her PhD from the school. And as if that weren't enough for an alum, she now teaches many of our students as we equip them to serve the needs of communities around the world. Well, this week, the School of Public Health officially launched its 5-year strategic plan for anti-racism. And one of the goals in the plan is to offer continuing education opportunities to help our community stay current on best practices in public health, especially as they relate to anti-racism. And I'm very grateful to Dr. Hardeman and to Marissa for their willingness to share their expertise and to help challenge us to learn and grow in this discussion today. So, questions are welcome during this event, and for our Q&A with the audience, yourselves, that's going to be at the end of our hour together, but you can submit questions at any time. What we'd like you to do is type your questions into the chat box, and we'll get as many questions to our panelists as time allows near the end. Now, before I exit the video, I do want to introduce Bukata Hayes. And I think the most important thing about Bukata is that he is the son of Dia Damani and Karen Hayes. He is husband to Lisa and father to Damani, Jalen, Xavier, and Zuri. And in addition to this, he recently became the first ever vice president for racial and health equity at Blue Cross Blue Shield of Minnesota. And prior to joining BCBS, Mr. Hayes served for 15 years as the executive director of the Greater Mankato Diversity Council, which is a nonprofit focused on diversity, inclusion, and equity in southern Minnesota. And in March 2020, he co-authored a book that was entitled Right on Race to be Right on Race. Love the wordplay. It's a resource journaling guide, which is a self-study on race, highlighting its many impacts on our communities. He also co-hosts a southern Minnesota-based radio show and podcast called DEI, Engaged Exchanges, which discusses issues about diversity, equity, and inclusion, and local and statewide leaders. Bukata received his bachelor's degree in exercise physiology from the College of St. Scholastica in Duluth. He is a member of and sits on the boards of numerous organizations, including as a member of the executive committee of the Mankato chapter of the NAACP, and he is also president of the Martin Luther King Commemorative Board. He is vice president of the Blue Cross Blue Shield Foundation Board and is also a member of the Blandon Foundation Board. Blue Cross and Blue Shield in Minnesota, with headquarters in the St. Paul suburb of Eagan, just right down Highway 13 from where I am now. That was chartered in 1933 as Minnesota's first health plan and continues to carry out its charter mission today as a health company to promote especially a wider and more economical and timely availability of health services for the people of Minnesota. Blue Cross and Blue Shield in Minnesota is an independent licensee of Blue Cross and Blue Shield Association, which is headquartered in Chicago. Earlier this year, BCBS made a transformational gift to establish the Center for Anti-Racist Health Research at the University of Minnesota School of Public Health, a gift for which this school is enormously grateful. So thank you for joining us today. And with that, I'm going to hand it over to Bukata.
Thank you so much, John. Thank you for having me today. Just want to say a few words. One, Blue Cross Blue Shield of Minnesota declared racism as a public health crisis. And so that meant that we were going to take an all avenues approach to the elimination of the entrenched disparities around race and health, in particular as it impacts BIPOC folks within our state. And so inherent in that declaration is that we were going to do things differently to get different results than we have been previously getting. And so it is our pleasure, and Blue Cross is proud to be the inaugural founder for the Center of Antiracism Research for Health Equity. Our investment of $5 million to support the launch of the center is a point of pride for the entire enterprise. It is a signature part of our commitment to advancing racial and health equity, a commitment that reaches within our enterprise, to our members, and most importantly, to our communities. We were compelled by Dr. Hardeman's vision, which you'll hear about today. We're excited about the sheer potential of this partnership that brings together our state's land-grant university and our state's first and largest health plan together in the service to the Minnesota community. While we were the inaugural funder, we are eager and we invite others to join us in the support of the center, excuse me, so that Dr. Hardeman's vision can become a reality. And so with that, I will introduce, I have the pleasure to introduce Dr. Hardeman and Marissa. So Dr. Hardeman, known and admired by many on this call, Dr. Hardeman is a reproductive health equity researcher whose program of research applies the tools of public health science and health services research to elucidate a critical and complex determinant of health equity, racism. Dr. Hardeman leverages the frameworks of critical race theory and reproductive justice to inform her equity-centered work, which aims to build the empirical evidence of racism's impact on health, particularly for Black birthing people and their babies. In 2020, she was named the first Blue Cross Endowed Professor of Health and Racial Equity and is the founding director of the Center for Antiracism Research for Health Equity. Dr. Hardeman's overarching goal is to contribute to a body of knowledge that links structural racism to health in a tangible way, identifies opportunities for intervention, and dismantles the systems, structures, and institutions that allow inequities to persist. And now I'll introduce Marissa Evans, a journalist and expertise in maternal health and beginning her master's in public health in maternal and child health at the U of M this fall. Joining Dr. Hardeman in the conversation today is Marissa. Marissa covers healthcare and communities of color in California as a staff writer for the Los Angeles Times. Before joining the Times in 2021, she worked for the Star Tribune in Minneapolis, where she covered housing, Black community trauma after George Floyd's death, how communities of color have been affected by COVID-19, and how Minnesota allows private hospitals to seize tax refunds from consumers with unpaid medical bills. Her work has appeared in The Atlantic, Medium, Oprah Magazine, and other outlets. Evans is also a trainer with the Ida B. Wells Society for Investigative Reporting, which aims to increase the ranks of journalists of color in the field of investigative reporting. She graduated from Marquette University with a degree in journalism, and I'm excited to share that she will be joining the University of Minnesota School of Public Health this fall as she begins her Master's of Public Health program in maternal and child health. Welcome, Marissa. Before we jump into our conversation today with Marissa and Dr. Hardeman, we'll share a brief video that introduces you to the Center for Antiracism Research for Health Equity.
So I think a lot of things need to happen to change how racism impacts health and to dismantle really the impact of racism on health so that all communities are able to achieve health equity. So I would say racism impacts people throughout the life course. We know that Black and Indigenous infants in particular are twice as likely as their white counterparts to not make it to their first birthday. And that's true here in Minnesota as well as nationally. The impact of racism on health is starting before a baby is born, but once they're born, if they survive that first year of life, there's going to be an onslaught of disadvantage that comes their way across the life course. So we know that 1 in 1,000 Black men and boys have a chance of being killed by a police officer in their lifetime. Here in Minnesota, we are seeing that Black people are more likely to die from COVID-19, and they're also dying at younger ages. So I think COVID-19 is actually the perfect example of how we can ask different and more sort of nuanced questions to get at the heart of what's really going on and therefore figure out how to change it. So early on, the question was, why are Black people so sick and why are Black people so, disproportionately impacted? But we didn't stop to ask the question, what are the potential systems or policies that are rendering Black and brown communities more susceptible to this disease? And I think by shifting the question, we understand then that, when we look at the data, Black, Indigenous, and Latino communities are more likely to hold jobs where they are, exposed daily to COVID-19 because they aren't able to work at home. When we talk about an anti-racist approach to research, we're talking about an approach that understands history. An anti-racist research approach also requires that we center at the margins, meaning that the people that are closest to the pain, the people that are grappling most with these issues and are impacted most deeply by these issues are able to lead the work. We have 4 goals that we will focus on in this research center, and those are research, education, authentic community engagement, and also narrative change. And they can't sort of exist disconnected from one another. They are all very much intertwined and sort of support each other, because without authentic community engagement, we can't have real evidence-based research to inform policy and to inform and create change. Again, I think that the education piece is incredibly important as we think about our future in public health and our future workforce and those who are really truly committed to anti-racism and ensuring that it shows up in the ways that they practice public health and are working towards health equity. So the generous gift from Blue Cross and Blue Shield of Minnesota, I think, speaks to the power of collaboration and their bold vision, along with my bold vision of a healthier Minnesota. For me, success, in the biggest sense of the word, would mean that everyone has the same opportunity to be healthy. I think success looks like every life being valued in the same way. I fully acknowledge we are a very long ways from that, and that our center will be one part of a larger effort and push that we're seeing, and movement, frankly, that we're seeing across the country to dismantle racism in all of its forms and to achieve equity.
Thank you, everyone, so much for joining us. Once again, my name is Marissa Evans. I'm a reporter with the Los Angeles Times in Los Angeles, just moved from Minnesota. So it's nice to be somewhat back, even just virtually to some degree. Again, so excited to be with Dr. Hardeman. I followed her work while I was still at the Star Tribune. So again, just incredibly excited to be here and to experience her beautiful mind with all of you just as the same. So just to give a quick run of show, we are going to do about 30 to 35 minutes of questions. As Dean Finnegan said before, you are welcome to submit questions. We'll try to get to as many as possible. We're going to have maybe 10 to 15 minutes of questions, depending on how the conversation is flowing. So start thinking of those questions, and we'll try to get to them at the end, toward the end of the program. But thank you again, Dr. Hardeman, for being here and for suggesting we have this conversation. I'm excited to be here with you. I guess I feel like it's important to start start from the base, start from the beginning,
Sure.
based on where we are right now in this moment in public health. So I'm going to do a softball question. I hope you think it's softball. What grade would you give the United States in its response on COVID-19?
Oh, wow. So wow, yeah, I would say we have failed our people in the broadest sense of the word. Honestly, I think that, and this is something we could spend the next 30 minutes talking about, just this issue, right? But we have not done all that we can to ensure that every single life in our country and in our communities is valued in the same way. And we allowed politics, right, to play a significant role in our response in a way that has been incredibly harmful, and particularly for communities of color.
When you're thinking about this failure, and also during the pandemic, you're starting this important work with the center, how is the pandemic guiding or influencing that work as you start the course of it, the center?
Yeah, that's a great question. So, I mean, I think first and foremost, one of the many goals of the center is really to center at the margins and to really lift up the voices of folks who have been left out, have been intentionally and historically left out of the conversations. And so, a lot of what, we've done, and with that in mind, has been to seek out and understand and lift up the voices, whether it's due to the disproportionate impact of COVID-19 on communities of color here in Minnesota and the Twin Cities, or whether it's the impact of being disproportionately surveilled by police, or the fear of living in communities where one might be killed by a police officer, or listening to Black women who are fearful that they are going to experience one of the many adverse health outcomes or birth outcomes that we know are persistent for Black birthing people in our communities. So and part of that also is changing the narrative, right? So, especially with respect to COVID-19, what we saw early on is that, there's this discussion, I said this in the video, the clip that just played too, that the narrative was really, well, Black people are or people of color are sicker, and so therefore they're going to be more vulnerable, right, to getting COVID and succumbing to COVID. And there was very little sort of thought put into the fact that there are all of these structural and systemic issues at play that are contributing to rendering people of color less healthy, right? And then they're exposed to COVID because of those structural issues. And so we at the center have really tried to play a role even early on as we're launching, right? We're still in the launching phase of the center, but we've tried to step in and play a role in sort of helping to shift the narrative there and use and leverage research to support narrative change in that way.
Got it. Now, when you talk about research, you're talking about all of these major things you want to get done and how you want to influence that with the center and its mission and vision. We obviously, everyone here understands what happened with George Floyd and his untimely death last May. And all these racial reckonings that happen across industries, across all of these sectors, including in healthcare. I'm curious how even his own death is guiding the center's work as well.
Yeah, and I will start by saying, George Floyd's murder has not just guided, the work of the center, but it is central to the core of my values and the work that I do and the research questions I ask and how I show up, how I engage with community, with my colleagues, right? So, and that started honestly before George Floyd, because there were many, many, many before George Floyd. And I actually started the work of from an academic or from a research perspective of understanding the impact of police violence on health outcomes, particularly reproductive health outcomes, in the aftermath of Philando Castile's murder in Falcon Heights in 2016. And and we've continued over the years to build on that work and to really develop an evidence base that helps people to understand that community context, social context matters for how people's ability to be healthy and particularly to have healthy babies. And so as I think about the Center for Antiracism Research for Health Equity and how George Floyd's murder has influenced us, and Daunte Wright's murder, right? Because we were in the process of launching as Daunte Wright was was shot and killed in Brooklyn Center. And, you know, our goal, what we see as our role is in addition to creating the empirical evidence that really tells the story of the harm, which I think for those of us who are part of that lived experience, it feels very obvious, right? We feel that pain every single day. And so it's also being able to put that empirical evidence forward to say, this is what that reality is like, and here's what needs to happen to inform policy change and, you know, system level change. We've also thought about George Floyd's murder within the center as a sort of motivating force around how we, again, that narrative piece, that narrative change, and really sort of helping folks to understand racism as a fundamental cause of health inequities. And because it's a fundamental cause of health inequities, we have to be able to sort of dig into all of these complex ways in which it shows up, one of them being police brutality or police violence.
When you're thinking about being the very first director of the center, you know, you talked again, you're studying, your work includes studying, I mean, I'll say very sad things like police violence, Black and brown people being killed at the hands of police or just through different public health disparities.
Yeah.
How do you, like personally, so taking your PhD hat, your MPH hat, all of those different hats you wear off, how do you personally, emotionally navigate the weight of the work you're trying to do?
Wow, that is such a hard question, Marissa, because I feel like I don't always do that well, and I'm working really hard to do it better, right? And I think that's, you know, I was reflecting on this exact question or a similar question the other day as we watched, you know, famous tennis player Naomi Osaka, right? Actually be in some ways very supported for her decision to protect her mental health and to take care of herself. And in other instances, you know, demonized for it, right? And really sort of shunned for choosing that. And, you know, breaking news this morning, Simone Biles has decided to step back and take care of her mental health rather than, you know, having competed in the team finals. And I think we're starting to see a sort of trend there, right? I mean, if a trend could be two people, I mean, that's two famous people, right? But, you know, it's something that I think we don't easily do. And for me, the struggle is there's so much urgency here. There's so much urgency in the work. People are dying. People I care about, people in my community are dying, are being harmed. And so it makes it really hard, honestly, to be able to sort of take a break and to step back, but also, I've had incredible mentors and people along the way who remind me that, you know, I have to take care of myself in order to do the work, right? And that means spending time with my family, you know, hanging out with my 8-year-old daughter, going on vacation and actually unplugging. And I also think a lot about the folks who are coming behind me, right? And how important it is to model for them, all of these incredible scholars of color who are coming behind me who are committed to the work. But you know, it's certainly a marathon and not a sprint. And so you know, modeling for them that it's important to step away and to breathe and to do, you know, and take care of oneself is incredibly important.
You know, when you're thinking about, again, the last year we've talked about the pandemic, all these different police violence related deaths, particularly among Black and brown women. And you have people for the very first time in 2020 really being introduced to the idea even, not even just the definition, but the idea of systemic racism, structural racism, institutional racism, these very academic sounding words. You know, you had people going to the Barnes and Noble's table that says books on race. It's okay if you get a book from there, but, you know, books on race, to try and understand the moment, right? To try and be a better citizen, a better steward of understanding what it means to be part of America, but also to navigate the racial inequities of America. But now with the center, you've introduced in a lot of ways this idea, the concept of anti-racism research. So again, taking that PhD hat off, the MPH hat off, how do you explain that term to non-public health people? I know there's a lot of public health people on the call, but I'm curious, how do you talk about this work in a way that is tangible for people?
Yeah, I love that question. and I agree, like, 2020 was sort of this year of awakening for folks who have had the privilege of not having to understand this reality, and frankly have not learned our history, right? Because our school systems, across the country have failed in that way of really teaching the historical context of why why racism exists in America and how that's sort of impacting our current reality. And so I will say that I think Ibram Kendi's book, How to Be an Anti-Racist, which I think like flew off shelves right after George Floyd's murder, certainly has helped bring folks along in a way that feels, I think, accessible to a lot of people. And I'm sure there's folks who would debate that, right? But that's not what we're here to do. But I think also, again, it's back to that narrative change of, making sure that we are, to your point, speaking in plain language and really helping folks make those connections. So the way that I talk to folks about, what anti-racist research is and what I do as a health equity researcher is really to say that it is research that's grounded in an understanding that racism is a fundamental cause of health inequity. So first and foremost, we have to agree or understand that sort of at the foundation of why health inequities exist and persist is racism. And, and then we have to be able to explore the why behind that. And so some of the why is then saying, okay, so let's talk about our history. And I'll, often put out an example, usually it's in the maternal child health space of, do you know who James Marion Sims was? And what his research, how he built his entire program of research on the backs of Black enslaved women who didn't have a choice, weren't able to consent, right? And then, talking about sort of how to, and that idea or those actions were based on ideas around race and who was advantage and who was not, right? And so then walking folks through that historical context and how that contributes to the Black maternal health outcomes that we see today. And then, I think the other important part of talking about anti-racist research is then saying, so we have these problems that we've been grappling with for 400 plus years. They continue to persist, and have we, let's step back and think, have we actually asked the folks who are most harmed by these disparities, the communities, the people, the populations that are experiencing these inequities on a day-to-day basis, how often do we actually step back and ask them what the solutions are, right? Because the other key part of anti-racist research is that we go to those who are closest to the pain and step back and create the space for them to lead the work.
Got it. Well, when you're thinking about even explaining this work to, for example, white public health researchers, there are researchers who still grapple with the idea of racism in public health, right? So how do you guide them? How do you walk them through this work as well? I mean, or do you just leave them behind and they'll get it together eventually?
Yeah, yeah, that's a great question, because I think it's not about leaving anyone behind, but there's also like critically important work to do, right? And I think, my experience has been that there's a large and long sort of wide spectrum of where people fall in their, in both their understanding, their willingness to understand, their ability or the time they've taken to sort of critically self-reflect and think about sort of where their privilege lies or where it doesn't and things like that. And so I think, from a timing perspective, like you have to take all of that into account as you're bringing folks along, right? But also, there are incredible scholars across the country who are doing this work, and I would say incredible Black scholars in particular. Dr. Chandra Ford put forth a research methodology based in anti-racist research years ago, probably 10 years ago now, called public health critical race praxis. And, and so pointing folks who are interested but aren't quite there yet, or really trying to get, to the body of scholarship across the country, I think is a really important sort of starting point. But we also have to be willing to be a part of sort of paradigm shifts, or what I would refer to it as. I think, as someone who has been trained trained well, right? I've been trained as a health services researcher, health policy, with a focus on the sociology of health and illness. And there's certainly parts of the socialization process and getting a PhD and that training that, tell us to think about how to do research and how to approach the work in very specific ways. And what we're seeing now is this opportunity as we grapple with these sort of intractable, what feel like sort of seemingly intractable issues, is that we have to shift that paradigm and rethink how we're training our students, rethink how we are doing our research and our approaches to the research, to be able to get different results, right? Why continue to do the same thing that yields the same results? And I think what we've seen in the past year certainly is sort of more a willingness from folks who are perhaps maybe kind of not making that progress prior to 2020, being more willing to do that, but also, it's a resource issue too, right? So, authentic community engagement, when it's done well and done right, it takes time. It takes a lot more resources. You're asking for people's time and community. You're asking for them to step away from their day jobs and things like that to speak with you. And that takes resources to support. And so, I think what we're seeing and what we continue to need more of is the resources to support the work.
You just touched on a really good point. You have obviously this public health fan base of sorts, which is really, I find joy in observing on Twitter or even on here. You also have institutional support, you have funding support. But when you think about the greater landscape of public health research, what keeps more anti-racism in public health research from happening?
Wow, that's a huge question, because there's so many different levels to it, right? So, certainly, the way that we fund research is a barrier, right? So the way that proposals have to be written, the frameworks that reviewers are using, the rubrics that they're using, so I had the chance a couple of weeks ago to speak with the NIH about my work around measuring structural racism, because they're really interested in training their program officers to begin to sort of think differently when they're reviewing the methods for proposals and trying to think what we would call, what they would consider sort of outside the box as they are doing that work. So I think, and then we have, in academia, there's certainly we're working on publications all the time, but then you have editors and reviewers there who may not understand these issues. So then you're spending time sort of walking folks through what structural racism is, or what institutional racism is, why it's important, or why you chose a specific sort of methodology or model versus another one because of the work that you're doing. And there's also, I feel like I could go on and on about sort of the barriers along the way. Certainly, I have done this work for a while now, right? Without, hitting the pavement, writing grants and things like that, but without a ton of resources, right? And even now, I think we still have a long ways to go to build something that is sustainable. And I think that's the key to it as well, is that oftentimes what we see is sort of bursts of interest and support and resources for a few years, and then it fizzles out, right? And so that sustainability piece becomes a challenge. And without sustainability, then we're left kind of starting again at ground zero.
That makes sense. This week, the School of Public Health released its strategic plan for anti-racism. As a faculty member, as a leader of the center, what makes this strategic plan unique?
I would say the one thing that makes it fully unique is that Lauren Eldridge is an incredible leader for the school, and I'm just delighted that that we can count her among our ranks. Her leadership and vision for the work of DEI within the School of Public Health is incredibly important and visionary. I will say, one of the things that I think is important to think about with respect to the work that the school is doing, which is commendable and needs to be done, it's time, is to be thoughtful about sort of how the Center for Anti-Racism Research can support that work in a way, we're a research center, we're generating, evidence all the time around the impacts of racism on health and well-being. And so I would love to think about sort of how we as a center can sort of support building the evidence base needed as the DEI plan rolls out.
Got it. We've talked so much about the challenges that Minnesota faces. We could go on and on and on. We could spend all day talking about the public health issues that we have, or that I'm not there anymore, so that y'all have in Minnesota. But I'm curious, from your vantage point, are there breakthroughs or opportunities that Minnesota is actually charging ahead with that other states and maybe even other countries can learn from?
Yeah, wow. So I think, the thing Minnesota has going for it, and this is something that I'm sure every single person on this call has heard millions of times as alums and or just members of our community, is that, Minnesota is often, considered one of the healthiest states in the nation, which means we're doing something right. But what we also know is that when you pull back those layers, right, not everyone has that same opportunity or right to high quality healthcare and to be healthy. So when I think about what Minnesota is doing right, we're doing something right in the sense that like some folks are healthier, but that means also that we actually have, I would say, even more work to do, because our baseline, we're up here for some folks, but we're like way down here for others. I think that some of the great things happening, I'm a reproductive health researcher. Reproductive health equity is my passion and focus. And, the state recently passed the Dignity in Childbirth and Pregnancy Act, which, in addition to doing a lot of really important key things for birthing people generally in Minnesota, it really is focusing in on the fact that we have stark inequities or disparities in maternal and infant health. So in Minnesota, Indigenous and Black infants in particular are twice as likely to not celebrate their first birthday. And so, one of the things I'm excited about with the center is that we have been granted, we will receive a grant from the state to be able to develop an anti-racism and implicit bias training that will be required of all perinatal care providers in the state of Minnesota, with the goal of helping, as I described sort of what anti-racist research is, and sort of walking people through the historical context and how that shows up in contemporary health inequities, and really helping build a skill set for the providers in our state around anti-racist healthcare delivery. And so, it's legislation like that it leaves me, incredibly hopeful. I think that over the past year and a half after George Floyd's murder, as we, have begun to have really, I think, controversial and tough discussions around, community or policing and what that means, I think it's led to some really, I think, important conversations about actually what public safety is, and asking folks what public safety means to them. And so there's things like that give me hope. But I think we have a lot of work to do here, but I think we can do it. We have incredible students and incredible alums as well who are doing, jumping into the work as well.
When you think about, again, the pandemic, the current moment we're in the public health space, again, there are so many people who, are getting introduced to the concept of systemic racism for the first time. I guess, from your vantage point, how do you see systemic racism playing out right now in public health?
Oh, that's an interesting question. No one's ever had the opportunity to answer that question before. How's it playing out right now in public health? So I think it plays out in a lot of ways, right? So it plays out in, so I'll start with sort of the School of Public Health, right? Our institution, where we still have a long ways to go, frankly, when we look at who are on our faculty. And all of that is, deeply entrenched in systemic and structural racism, right? So we have an urgent need to diversify our faculty. I think the same can be said. I think we've done some incredible work around diversifying our student body, but certainly more work is needed in that space as well, because then that's our public health workforce, right? So as we think about who's out in the public health workforce and what they're learning as well, and ensuring that they are receiving a training that is well situated, and I would say in anti-racist praxis and anti-racist research, as well as in health equity, I think is incredibly important. It's something that schools of public health across the country are grappling with. And then, at sort of a broader level, when I think about, what the field of public health is grappling with when it comes to systemic racism, I think COVID-19 is the perfect example. And even now, as we grapple with sort of the vaccine rollout and the fact that, what we're seeing now is that most folks who wanted to get vaccinated have been vaccinated. And so then the question is, within this vaccine hesitant group, how do we approach that? How do we think about those conversations? I think public health has a deep history in educating communities, but this requires much more than sort of just sharing facts with folks. It's really, and this is where that intentionality around sort of understanding anti-racism and the historical context that has led to distrust, and why that's important to be a part of a conversation around vaccine hesitancy. And so I think that's where, those are just a few of the ways that I would say it's showing up in this moment.
Got it. I just want to take a moment. So we have about 9 minutes of our portion left, and then we'll get into the Q&A. So again, if you haven't dropped in your question yet, please do. We already see that there's a lot of different questions coming in, which is great, shows everyone's engaged. So again, just a few more minutes of questions, and then we will move on to the audience Q&A portion. You talked a little bit about vaccine hesitancy, and I've seen this play out on Twitter. I've seen this in different papers I've also been reading for my own work. Where is vaccine hesitancy the right term at this point? Do you think it's the right term to use at this point, at this stage of the vaccine rollout?
That's a great question. And no, not necessarily. And I actually haven't read anything about this recently, but I think that actually vaccine hesitancy, or the vaccine hesitant, has become stigmatizing in a lot of ways, when really we're dealing with a population of folks who have been or have had family members who have been harmed by the healthcare system, or not even just the healthcare system, right? But our country does not have a strong track record, right, of uplifting and valuing all lives equally, right? And so, I think we have to be really thoughtful about how we talk about that and how we engage, again, how we engage with in conversation and in community with folks who are feeling concerned.
I'm curious, as you think about the months ahead with the Delta variant, still continuing trying to get people to get vaccinated, is there still time to turn it all around? Like, can we end this pandemic in a matter of months?
I'm feeling cynical today. The CDC just announced that they're going to likely be requiring everyone, vaccinated or not, to mask, to go back to masking. So if that tells you anything, I don't know. In this moment right now, you could ask me tomorrow and I might have a different answer. In this moment right now, I don't feel hopeful that we will turn it around. I think we're too far sort of down the line to turn it around in the next few months, which is heartbreaking because there has been so much suffering, and not just, there's been so much suffering and so much loss. Like I often return to your piece, Marissa, on the relentlessness of Black grief. Folks, if you haven't read it, it's in the Atlantic, please read it. It's beautiful. And I think such an important part of what's missing from the conversation far too much, particularly this idea that, we have lost we've lost so many people who didn't even get to realize, you know, their full potential, right? I think you worded it as they were denied the chance to be their ancestors' wildest dreams. And that just like hit me, because I mean, I think that's certainly the case for the COVID pandemic, but also, you know, when I think about Black maternal mortality and morbidity and infant mortality, and through all, you know, it's this denial of opportunity in a way that is unnecessary.
I'm gonna ask another question. I mean, you could be cynical about this one too. I don't know. We'll see what happens.
Okay.
You know, the Biden administration talked a lot about how racial equity is at the center of a lot of their work: healthcare, housing, civil rights, all of that. That's one of the pillars of what the new administration is trying to do. But I'm curious, again, knowing what you know about your own work, knowing what you've seen with the pandemic, knowing what you've seen about all the other public health issues that have not gone away with the pandemic, can we end racial health disparities in our lifetime?
Man, Marissa, this
Good.
I know, I love it.
I do.
This is great. Oh, wow. In our lifetime. Yeah, this is a question that changes, my answer changes to day. I think today my answer is probably not, but there's other days when I look at the youth, right? And even when I look at my students, my MPH students, my doctoral students, even when I look at my daughter who's 8 years old and her friends and the things that they're saying and the letters that they're writing to President Biden and Vice President Harris, and it gives me so much hope. But also, you know, we are talking about issues that have been around for 401 plus years, right? And so, and there's many people that came before us that have been doing this work to get us to this point. So I think we will be further along in our lifetime. Certainly. I mean, we already are. Yeah, I don't know how far, but I think it's possible, right? And I think that's the important part. Like, I think if we decided today that we were gonna do it, and by we, I mean the folks who hold and wield the power, it could happen. I absolutely think it could happen. But I think what worries me or makes me sort of more cynical is that, I mean, and this goes down a whole nother sort of academic rabbit hole that we probably don't want to go down. But honestly, when we can't separate inequity and racism from, frankly, from capitalism and the generation of capital and the importance of that in our society, it makes it really hard.
Got it. Okay, so we have about 12 minutes left in the program. We already have good questions, and so I'm going to end our portion now, Dr. Hardeman, and just get right into like the stuff of some of the questions I'm seeing. These are all good questions. Good. Keep them comfortable. The first question for the Q&A portion, we've had a number of questions around the following. How can white researchers and/or public health practitioners participate in or lead, anti-racism research without taking up space that doesn't belong to them?
So I would first say, I think the lead part is important. We don't have to, and even myself included as an academic, I don't have to lead all the things. You don't have to lead we don't have to lead all the things. There are people who, you know, there's other folks that should be leading the work. And I think it's important to go into and approach the work with that in mind, first and foremost, right? There's so much talent and so much brilliance out there that has been completely untapped because no one has stepped back to give that brilliance a voice. And so I think that's important to remember. I think, you know, deeply understanding the work, deeply understanding health equity and anti-racism, and being able to have a conversation, whether it's with your family members, with your colleagues or coworkers, and in your workplace, is a really important starting point, right? Because if you can't say the words, if you can't name it, if you can't sit down in whatever space you're occupying and ask the question and reflect on the question, how is racism operating here? We're not going to get very far. And so I think those are sort of those initial ways that we have to be willing to to do the work, engage in the work, and to step aside and give voice, to create space for voice for folks who need it and deserve it. Sorry.
No, you're fine.
Okay.
Another question from the audience. Have you seen any promising research being conducted addressing institutional racism within healthcare systems?
Yes. There's a lot happening in the maternal child health space. Dr. Karen Scott, who's at UCSF, Dr. Monica McLemore at UCSF, are doing a lot of really incredible work in that space. Around how institutional racism shows up in healthcare delivery for settings for Black birthing people. Paris Adkins Jackson, who's at Mass General in Boston, is doing some really, really innovative work around how to measure institutional racism in healthcare settings. And we're actually collaborating with this. She's collaborating with the center on a proposal right now that I think will help to sort of dig into that. But there's, and then also I would say, foundational to that work is the body of work that which is how one of the ways that I sort of got my start in this space was with one of my mentors who was in family medicine and community health here at the University of Minnesota, and really has led the building of a literature around implicit racial bias in the clinical encounter and healthcare delivery settings. And while I will say all day like a broken record, we have to move beyond implicit bias to talk about institutional structural racism. I think it's important to acknowledge that if it weren't for her work, Dr. Van Ryan's work in the early 2000s, I wouldn't be able to say institutional racism, right? Also, if it weren't for the work of Dr. Kamara Jones, who has been an incredible leader in the anti-racist public health space, I wouldn't be able to do the work that I do. But yes, to the initial question, there's some great work happening in that space.
Are there any validated tools for measuring / assessing racism in health systems and or healthcare delivery?
We're working on one. There's some great tools that are surveys or measures that look at sort of ask people their perceptions, right, of discrimination or institutional racism within healthcare settings. But one of the things that we're working on within the center is the development of a validated measure tool that will get at, because we know institutional racism is playing out, and it's about more than sort of a perception of, and I say perception in quotes because it's not a perception. If you experience racism, you experience racism, right? Point blank. But also, I think it's important to understand that it's baked into the system or the institutions, right? So it's going to dictate who you see, even down to like sort of who you see hanging, what pictures you see hanging on a wall in a hospital or in a clinic, right? Who's in the C-suite, who's cleaning your, the floors of the clinic, and all these other ways that it's manifested. And so we're really thinking hard about, so how do you capture all of that? So stay tuned. But
another question from the audience. Given the impact of isolation during the pandemic, how will the center look at mental health inequities?
Oh, that's a great question. So I don't know, honestly, and I think it's a really good, important topic. It's not one that any of our current researchers are focused on, but I mean, absolutely, the isolation of the pandemic and many other things that happened, right, in the past year and a half have certainly sort of made mental health a primary issue, and one where there's racial disparities also in access to mental health care.
Another question from the audience. In its DEI plan, does BCBS Minnesota and Center for Antiracism envision requiring its contracted providers of specific health plan products to also be actively engaged in anti-racism work?
Sorry, can you say that again, Marissa?
In its DEI plan, does BCBS Minnesota and the Center for Antiracism envision requiring its contracted providers of specific health plan products to also be actively engaged in anti-racism?
So I would say that is outside of the scope. The DEI plan that Dean Finnegan mentioned in his opening remarks and that Marissa mentioned is the DEI plan for the School of Public Health, which is separate from the work of the center and the work that Blue Cross is doing. So I can't necessarily answer that question.
Another question, how will the center partner with the School of Medicine to address issues such as race-based medicine?
So that, wow, yeah, that's a really, so I wrote my dissertation on medical education and sort of the role that race and racism played, or the lack of sort of training in that space for future physicians. And there's some really fantastic physician scholars who are doing work around sort of sounding the alarm on race-based medicine. And so, and certainly some of my work sort of sits in that space, but I think honestly, the medical students, particularly here at the University of Minnesota, have done an incredible job of leading the charge there, as well as colleagues that I collaborate with all the time in the med school, like Dr. Brooke Cunningham and Dr. Andrea Westby.
Another question, and we only have a couple minutes left. Can you comment on the partnerships that the center has or will have to advance this work? What are the partnerships and why do they matter?
Yeah, so to be clear, we are still in the launching phase. We're hiring staff and sort of preparing to stand the center up. We do have some partnerships already that are, some research partnerships with University of Pittsburgh and a great scholar there, Dr. Dara Mendez, with UC Davis and Dr. Michelle Coe, and some work around the measurement of structural racism, and many others that I'm probably forgetting right now. And then we'll turn soon to focus on, continuing to develop and cultivate our partnerships within community. And I want to be incredibly sort of authentic and intentional about those, cultivating those relationships, because I think so often a lot of harm comes from when we sort of move too fast in that way. So stay tuned, join our listserv, the CARE listserv, so you can stay up to date as we move towards that work.
Great. And last question, health outcomes are complicated and multifaceted. How does your research, just the screen moved down, how does your research account for other determinants of health outside of racism?
So that is a long conversation that we probably don't have time for, but I will say at the crux of my work is the fact that, structural racism is a fundamental cause that then dictates why the social determinants matter for health, right? So because of structural racism, neighborhood context matters, redlining or residential segregation and other sort of social determinants matter for health. And so we are always thinking about both those mechanisms and the pathway, as well as sort of all of the ways that it's manifested.
Great. Well, thank you, Dr. Hardeman, so much again. Thank you to everyone who's here, and our Dean Finnegan will close us out.
Thanks so much, Marissa.
All right. Well, thank you so much. I just have to say I've learned so much out of this conversation. And I have a few observations real quick here. Public health emergencies really can't be solved by public health alone. And by its very nature, we see public health as collaborative, multi-sectoral, multidisciplinary, because the public health challenges that we face are so large and complex. Now, Marissa's presence here today and Dr. Hardeman's presence here today represents two major institutions that are part of the solution, and that's the science and the media. How do you change the narrative and have an effect on people when their ears and their eyes are open? Now, recently, Laura Helmuth, who was editor-in-chief of Scientific American, she talked about public health emergencies as syndemics, S-Y-N-demics, syndemics. And the idea is that public health emergencies are not just about the nature of viruses, nor is racism about people's feelings about race alone. A syndemic is about an ecosystem that is conditioned to encourage rather than to prevent the spread of a public health emergency. And the dynamics are shaped and they're amplified by social, biological, and political factors, including systemic racism, pre-existing health disparities, xenophobia, disinformation, and misinformation. Changing the conditions of the ecosystem is the grandest challenge of all for public health and all of us. And therefore, we are all in this ultra marathon because people's lives depend on changing the ecosystem and its outcomes. I want to just say thank you to Dr. Hardeman and to Marissa. This has just been a terrific discussion. I also want to thank Bukata Hayes and also Blue Cross Blue Shield of Minnesota for their partnership in this. This is a step, as Rachel Hardeman said, this is a step down a long road. It was steps have been taken before, steps will be taken after. But the steady commitment of all of us that work in public health, and everybody, no matter what sector you work in, that's the level of commitment that public health really needs to stimulate and build. Thank you, everybody, for being here today. And we look forward to seeing you again in the future as we talk more about the accomplishments in this area and the research and the questions that keep us all up at night. Thank you, everybody.